Welcome. We are the team behind the Urban Herald, and today we're really diving deep into our comprehensive guide on global breast cancer care.
That's right.
Our mission today is pretty direct, pretty critical, really. We want to cut through all that seasonal noise, the momentary awareness campaigns.
The October focus.
Exactly, and focus squarely on the evidence-based actions, the systemic changes that actually truly save lives every single day of the year.
Yeah, precisely. We put this guide together specifically to challenge that idea that breast cancer is just an October thing.
Right.
Because the reality, what our research really brings to light is this urgent need to move beyond just awareness, that sort of passive knowledge, towards sustained, actionable healthcare practices.
Actionable being the key word.
Absolutely. We need to measure success differently, not by pink ribbons, but by survival rates across the whole globe.
And the scale we're talking about here is, well, it's immense, just to put a number on it for you.
Okay.
We're looking at 2.3 million new diagnoses globally. That's the latest data. It really is. Breast cancer isn't just a major health concern anymore. It's actually solidified its position as the single most commonly diagnosed cancer worldwide. That's, 11.6% of all new cancer cases?
Yeah, about that. It just underscores why we can't be complacent.
And what's really critical for you, the listener, to grasp is that the whole landscape of care is fundamentally shifting right now. This year, 2025, it's kind of being defined by these major policy updates, particularly around screening.
That's a huge part of it. We've seen quite a few countries, the United States probably being the most prominent example recently, officially lower the recommended age for starting regular screening down to 40.
And that's not just a small tweak, is it?
Oh, not at all. It's a massive logistical shift. And a philosophical one, too. It really demands that all of us are better informed about the details, the nuances of care.
So that really sets the stage perfectly for this deep dive. Our focus is shifting away from what we sometimes call pinkwashing, that sort of superficial commercialized activism. We're zeroing in on three main pillars. First, understanding the evidence behind screening guidelines. Second, internalizing real risk reduction strategies. And third, and this is crucial, tackling those profound, frankly unacceptable global disparities in survival rates that our data just keeps showing us.
Okay, let's start with the hard numbers. This comes from the Jobocan 2022 report, and it's pretty sobering. If you really want to get a sense of the speed and scale of this disease, think about this.
Okay.
Our sources confirm that every single minute, somewhere in the world, 4 women are diagnosed with breast cancer.
Every minute. 4 women.
And tragically, in that same minute, 1 woman dies from it.
So just in the time we've been talking.
Exactly. Dozens of lives have been completely altered.
Forever.
That rate, 4 diagnosed, 1 death every 60 seconds, is just a horrifying way to measure the global burden. But what the Urban Herald Guide does so well, I think, is not just throw stats at you, but really analyze the context.
We have to look closely at this Human Development Index, the HDI contrast, because that's probably the clearest and honestly most heartbreaking illustration of the equity gap in healthcare.
Yeah, connecting it to the bigger picture is vital. The role of reliable, accessible healthcare infrastructure. It isn't just important, it's literally the difference between life and death for so many.
So let's break that down. High HDI countries.
Right. These are generally your developed nations. Think Canada, Western Europe, Australia, places with advanced healthcare systems. The incidence rate is actually quite high. Roughly 1 in 12 women will get diagnosed in her lifetime.
Okay, so it's common there.
Very common. But, and this is the key part, the mortality rate is remarkably low. Only about 1 in 71 women who get diagnosed will actually die from it.
High incidence, high survival. That makes sense.
It reflects those organized screening programs we mentioned, quick diagnostic follow-up, rapid access to surgery, advanced treatments like targeted therapies, hormone therapies, the whole package.
We see survival rates over 90% when caught early in places like the US, UK, Australia, because of that system.
Exactly. Now, let's contrast that sharply with low HDI countries, places where resources are severely limited.
Okay.
Often they actually have a lower overall incidence rate, maybe 1 in 27 women diagnosed in a lifetime. So fewer cases overall.
Right.
But the mortality rate is disproportionately, tragically high. 1 in 48 women diagnosed will die from it.
Wow. So wait, let me get this straight. Lower chance of getting it overall. But if you do get diagnosed in a low HDI country, you have a much, much higher chance of dying from it compared to someone in a wealthy nation.
Precisely. A significantly higher chance. It's a critical point we really need to understand.
So why? Why is that disparity so vast? It can't just be the lack of screening, can it?
Yeah.
What are the systemic failures the data points to?
Well, it's fundamentally systemic, like
Mm.
you said, and it's really rooted in late-stage diagnosis and a massive infrastructure failure. In many low HDI settings, cancers aren't usually found through screening. They're found when someone feels a lump or has symptoms. That means the disease is often already locally advanced or even metastatic spread to other parts of the body.
So it's already much harder to treat by the time it's found.
Exactly. And then even if it is found, the treatment infrastructure often just breaks down. Maybe there are no specialized cancer surgeons or no reliable electricity to run radiation machines consistently.
Or even keeping chemo drugs cold.
Yeah, a lack of a cold chain is a huge issue. So even if you get a diagnosis, getting the full course of treatment might be impossible or simply not accessible. The result is these devastating death rates that look more like what the West saw decades ago.
And incidence rates are actually rising globally, aren't they? Almost everywhere.
They are, unfortunately, due to things like aging populations, lifestyle changes. But the fact that mortality rates are dropping significantly only in high-income countries, that just hammers home the value of systemic intervention.
Survival isn't random. It's a direct result of the quality and equity of the system around the patient.
Which brings us right back to our core philosophy shift: care over buzz.
Right.
We absolutely have to focus less on those superficial awareness campaigns, the ones that pop up for a month, and more on implementing real life-saving actions year-round.
Because awareness without access to care, it's almost cruel.
It really is. Finding a lump means nothing if there's no path to treatment.
So what are the foundational pillars the Urban Herald Guide highlights for effective year-round care? What needs to happen?
Okay, first, evidence-based screening programs. And critically, they have to be accessible to all socioeconomic groups. Income shouldn't be a barrier to getting screened.
Makes sense. What's second?
Second is comprehensive education. Empowering women to recognize changes in their bodies early, yes, but also helping overcome cultural barriers. Things like fatalism or modesty concerns that might stop someone seeking help.
Okay. And third?
Third, the rigorous elimination of healthcare disparities. We have to get to a point where survival is determined by biology, by the type of cancer, not by your zip code or your bank balance.
And that year-round commitment you mentioned, that's just non-negotiable for making any of this happen. It needs sustained investment. Policy changes.
Absolutely. And this global realization, this understanding, is starting to drive policy. You see the World Health Organization, the WHO, through its Global Breast Cancer Initiative. They've set a really ambitious goal.
Which is?
To reduce global breast cancer mortality by 2.5% per year.
That sounds like a lot. Is it achievable?
It's incredibly ambitious, but necessary. And achieving it relies entirely on dramatically improving early detection and making sure there's reliable access to treatment everywhere. That means infrastructure upgrades, policy changes happening every month, not just in October.
Okay, let's unpack what's often the most dynamic and, let's be honest, confusing part of breast health for many people. The screening guidelines.
Yeah, this is where things can get complicated.
The medical consensus is pretty clear, right? Early detection through regular screening saves lives. Full stop.
Absolutely. No real debate on that fundamental point.
But the big question is when to start screening.
Yeah.
And how often. And the answers vary drastically depending on where you live, your personal risk, family history.
And that raises a really important question for you, the listener. How do you navigate all this confusion when the official recommendations from different countries or even different organizations within the same country don't line up?
Right. Why do they differ so much?
Well, these variations often reflect some deep-seated differences. Things like national healthcare philosophies, budget constraints, different ways of analyzing population health data, and how they weigh the risks versus the benefits of screening.
Okay, let's dive into some specifics. Starting with the United States, especially given that massive update we saw post-April 2024 from the USPSTF.
Right, the U.S. Preventive Services Task Force. They're the independent panel, not government, but their recommendations carry huge weight, especially for insurance coverage.
So what was the big change?
It was pretty historic, actually. They formally lowered the recommended starting age for screening mammography from 50 down to 40 years old.
Wow, okay. And the frequency?
The current guidance is biennial screening mammography. That means every 2 years for all women aged 40 to 74.
What drove that specific change? The USPSTF is usually known for being Pretty conservative, very data-driven.
Yeah, they are. The rationale was robust, though, based on updated data modeling. They clearly acknowledged the undeniable rise in breast cancer incidence among women in their 40s.
Okay.
But more critically, they specifically called out the disproportionately high rates of aggressive, fast-growing cancers found in Black women in their 40s.
Ah, connecting back to those disparities we talked about.
Exactly. If those aggressive cancers aren't caught early in Black women, it significantly contributes to that devastating racial gap in mortality rates. So the thinking was, starting screening earlier for everyone was the most effective population-level strategy to try and tackle that specific disparity.
Okay, that makes sense. But I can already see a point of confusion for people listening. The official USPSTF guidance is biennial, every 2 years starting at 40. But then you have the American Cancer Society, ACS.
Right, a very well-known advocacy and research group.
And they still suggest annual screening every year for women aged 45 to 54. That difference, annual versus biennial, must leave patients wondering what to do.
It definitely can. That tension exists because the two groups weigh the evidence slightly differently. The USPSTF really prioritizes findings from large randomized controlled trials, or RCTs. They focus almost purely on reducing death across the whole population.
Okay.
The ACS, on the other hand, often incorporates data from observational studies, too. They tend to weigh the potential benefits of finding cancers even earlier, perhaps a bit more heavily, even if it might slightly increase the risk of what's called overdiagnosis, finding slow-growing cancers that might never have caused harm.
So different philosophies on balancing harms and benefits. What about getting it covered? Is the U.S. system set up for this change?
Well, the good news on the access front in the U.S. is that the Affordable Care Act generally requires most insurers to cover that biennial mammography for women aged 40 to 74 with no cost sharing, like copays or deductibles. That USPSTF recommendation is key for coverage.
Okay, good to know.
Yeah.
Now let's hop across the Atlantic. The United Kingdom's NHS program, that's a very different model, isn't it? Centralized, government-run.
Yeah, a completely different approach. The UK system is really based on maximizing the benefit for the whole population while being efficient with resources.
So how does their screening work?
They automatically invite women aged 50 to 71 for screening every 3 years.
Every 3 years. That seems less frequent than the U.S. biennial approach.
It is. That 3-year interval is calculated based on their analysis of balancing the lives saved through detection against the known downsides of screening, mainly overdiagnosis and the anxiety caused by false positives. Their system aims for the biggest population benefit using allocated resources effectively.
What about younger women in the U.K., women in their 40s, or older women over 71?
There's flexibility built in. Women aged 40 to 49 and those over 71 can still self-refer for screening if they choose to, so individual choice is still respected, even if they aren't automatically invited.
And is the UK system looking at innovations too?
Oh, definitely. The NHS is always evaluating new evidence. They're actively reviewing data on personalized, risk-based screening, moving away from just age brackets. And they're piloting the use of AI, artificial intelligence, to help read mammograms.
AI, interesting. How'd that help?
2 main ways. Potentially improve detection rates, acting like a second pair of eyes for the radiologists, and also help alleviate the huge workload pressure on their specialized radiology staff.
Okay, now let's turn to Canada. You mentioned earlier they're navigating probably the most significant controversy right now regarding screening age.
Yeah, Canada's situation is quite contentious. Their official national guideline comes from the Canadian Task Force on Preventive Healthcare. They recommend routine screening only for ages 50 to 74, typically every 2 to 3 years, similar to the UK in age range.
Okay, so what's the controversial part?
The really contentious point is that the task force explicitly advises against routine screening for women aged 40 to 49. They state that, in their analysis, the potential harms, like false positives leading to unnecessary biopsies and overdiagnosis, outweigh the benefits for that specific age group.
Wow, that's a strong stance against screening in the 40s. I imagine that's drawn criticism.
Oh, huge criticism. From Canadian radiologists, patient advocacy groups, they're very vocal about their disagreement.
Why? What's their argument?
Well, the core conflict really boils down to how you define net benefit. The critics argue that the task force's analysis seriously undervalues the importance of detecting those aggressive cancers that often appear in women in their 40s.
Right.
Advocacy groups keep pointing out that about 1 in 8 breast cancers happens before age 50. And crucially, these cancers tend to be the faster-growing, more aggressive types.
So delaying routine detection could lead to later stage diagnoses.
That's the fear. Later stages mean more intensive, more costly treatment, and ultimately potentially higher mortality. They argue the task force's focus on population statistics misses the individual risk for women in that decade.
It sounds like a real ethical dilemma balancing population health statistics against individual risk and potential benefit. How is this actually playing out on the ground in Canada?
It's interesting, even with those conservative national guidelines, the actual implementation often varies by province. Many provinces have created pathways that allow women aged 40 to 49 to proactively request or self-refer for screening.
Ah, so there's a workaround.
Essentially, yes. It ensures that the final decision often rests with the patient and her primary care provider, even if the national body advises against routine screening for her age group.
Okay, finally, let's look at Australia. Their Breast Screen Australia program seems to strike more of a balance.
Yeah, Australia's approach is quite thoughtful. They offer free biennial screening every 2 years with automatic invitations for women aged 50 to 74, similar to the UK model's core age group.
But what about younger women?
They make it easy for women aged 40 and above to self-refer. So they balance the resource efficiency of targeted invitations for the 50-74 group with broad accessibility for younger women who might be concerned or have specific risk factors.
And Australia is doing something quite specific regarding dense breast tissue, right? That's a big topic.
Hugely important, yes. Australia is really a global leader here. Dense breasts are common. Maybe 40% of women have them. And Australia actually mandates that women are informed if their mammogram shows dense breasts.
Why is that notification so crucial?
Because dense tissue does two things that increase risk. First, it can mask tumors on a standard mammogram, making them harder to see, which lowers the sensitivity of the test. Second, having dense breasts is itself an independent risk factor for developing cancer. It increases the risk about 4 to 6 times compared to non-dense breasts.
Wow. So knowing you have dense breasts is vital.
Absolutely. By mandating notification, Australia empowers women. They can then discuss supplemental screening options with their doctor, things like ultrasound or maybe even MRI, ensuring they get care that truly reflects their unique physiological risk profile. It's a great example of moving towards more personalized care.
Okay, so we've covered the external systems, the mammograms, the policies, the guidelines. Now let's shift the focus inwards to the individual. We need to talk about self-awareness. And this concept, it's really evolved, hasn't it? It's moved beyond those slightly rigid, maybe intimidating 5-step self-exam protocols many of us were taught years ago.
Yeah, absolutely. The modern approach is much more practical, much less prescriptive. It really emphasizes holistic awareness. It's more about knowing your body's normal look and feel day in and day out rather than sticking to a precise, maybe anxiety-inducing monthly checklist.
It's less about performing a perfect exam and more about recognizing change.
Exactly. The shift is from perfect technique to prompt recognition of anything different for you.
And I like the idea of incorporating this awareness into daily routines. While you're showering, getting dressed, putting on lotion. It makes the check feel more organic, less like a chore.
That's the key, making it part of your routine so you naturally notice if something's off. Consistency of observation is really the goal here.
And regardless of where someone lives, their income, their ethnicity, the international medical community seems pretty aligned on a core set of key signs and symptoms that should prompt immediate medical evaluation, right?
Yes, there's strong consensus on the warning signs.
Okay, so the most recognized one, obviously, is a new lump or thickening, usually in the breast, maybe in the armpit area.
That's the classic sign everyone thinks of.
But our guide emphasizes, and this is important, that early cancers often don't present as a textbook obvious lump. So what are the other, maybe more subtle signs people absolutely must be watching for?
Okay, good point. We need to raise awareness about changes in the overall size or shape of the breast, particularly if that change happens only in one breast. That asymmetry is a potential flag.
Okay, size or shape change. What else?
Critical skin texture changes, things like dimpling, where the skin looks like it's been pulled inwards, or puckering. And especially that specific texture, often described as an orange peel, the French call it peau d'orange, that usually suggests underlying inflammation or maybe more advanced disease.
Right. That orange peel texture is a serious sign. What about the nipple?
Nipple alterations are definitely high on the warning list, too. Watch for any change to the nipple itself. For example, inversion, where a nipple that used to point outwards suddenly pulls inward.
Okay.
Or a persistent discharge from the nipple, especially if it happens without squeezing, or if it's blood-stained. That needs checking out immediately. Also, any kind of rash or flaky, persistent skin change on or around the nipple.
Got it. And what about general inflammation signs?
Yes, persistent swelling, redness, or unusual warmth in the breast tissue. Sometimes these can mimic an infection, like mastitis, but if they don't clear up quickly with antibiotics or if you're not breastfeeding, cancer needs to be considered.
Now, what about pain? People often assume cancer is painful.
That's a really important misconception to address. Most breast lumps, thankfully, turn out to be benign, not cancerous, and crucially, early breast cancer is often painless.
Okay, painless, that's key.
Absolutely. So you can't wait for pain as a signal. However, if someone experiences persistent, localized pain in one spot that's very different from their normal cyclical breast tenderness, that should still be evaluated by a doctor.
So the core message here is,
The core message is, if you notice any persistent change, lump, skin change, nipple change, swelling, unusual pain that lasts for more than, say, 2 weeks, you absolutely must seek medical evaluation. Don't wait. Don't dismiss it, don't wait for pain, and don't wait for your next scheduled mammogram if you notice something now.
okay, very clear.
Okay.
Now let's pivot to something crucial, often forgotten, and tragically often fatal because of delayed diagnosis. Male breast cancer.
Yes, such an important topic to cover.
It only accounts for about 1% of all breast cancer cases, right?
Hmm.
But the mortality rates are much higher. Why is that?
It's almost entirely down to delayed diagnosis. Many men, and sometimes even their doctors, simply don't realize men can get breast cancer. There's a lack of awareness, so symptoms get ignored for far too long.
And the average age of diagnosis is older in men.
Significantly older, yeah. Around 67 on average, again highlighting that delayed detection. But the warning signs in men, while similar to women's, need amplifying because they're often missed.
So what's the primary sign for men?
The most common sign is typically a hard, painless lump located directly underneath the nipple and areola area. Because men generally have much less breast tissue than women, this lump can actually be easier to feel, but it's often dismissed as something else.
Okay, a hard lump behind the nipple. What are the other red flags specifically for men?
Other critical signs include nipple discharge, again, especially if it's spontaneous, clear, or blood-streaked. Also, skin changes right around the nipple, redness, scaling, or even ulceration where the skin breaks down. And any nipple retraction or inversion where the nipple starts pulling inwards is a major alarm bell in a man.
If there's a man listening right now, how should they think about their personal risk? Are there specific risk factors that should make them more vigilant or prompt a conversation with their doctor?
Yes, there are definitely known risk factors for male breast cancer. The single most significant one is carrying a BRCA2 gene mutation.
Ah, BRCA2 again.
Ooh.
We hear about it mostly for women.
Right, but it dramatically increases the risk for men, too. So a strong family history of breast or ovarian cancer, especially involving BRCA mutations, is really important for men to be aware of.
What else?
Other factors include Klinefelter syndrome, which is a specific genetic condition affecting men. Also, severe liver disease, like cirrhosis, can increase risk because it alters hormone balance. Obesity is a factor. And having had high-dose radiation exposure to the chest area earlier in life, maybe for treating lymphoma.
So if any of those apply, family history, BRCA, Klinefelter's, liver disease, radiation, men really need to be proactive.
Absolutely. Proactive about self-awareness, checking for those signs we mentioned, and definitely having a conversation with their physician about their risk.
Okay, this next section is really empowering, I think, because it shifts the focus away from just genetics or fate towards things we can actually control, choice.
Exactly. This is about agency.
Our research, and lots of other studies too, consistently show that roughly 22% of breast cancer cases in developed countries are associated with modifiable lifestyle factors.
22%. That's nearly a quarter of all cases.
Which means potentially preventable through changes we can realistically implement ourselves.
Yeah.
That feels like a massive, actionable number.
It really is. It's a huge slice of the pie that we can directly influence. And the power of prevention through physical activity specifically is just overwhelming when you look at the data.
Okay, tell us about exercise. How much does it help?
Regular, sustained exercise has been shown to reduce breast cancer risk by up to 25%, especially in postmenopausal women. That makes it one of the most cost-effective, powerful prevention strategies available.
25% reduction is huge.
Yeah.
But we need to be clear, right? We're not telling listeners they need to suddenly become marathon runners or elite athletes.
Not at all. That's the great news. The recommendation is actually remarkably straightforward and accessible for most people.
What is it?
The general guideline is at least 150 minutes of moderate intensity aerobic activity per week, or, if you prefer, 75 minutes of vigorous intensity activity.
Okay, 150 minutes moderate. What does moderate look like in real life?
Think brisk walking like you're late for an appointment, cycling on level ground, water aerobics, even vigorous gardening can count. The key is getting your heart rate up a bit.
And you don't have to do it all at once.
Absolutely not. You can break it up. 10-minute bursts throughout the day are just as effective. Consistency, day after day, week after week, is much more important than hitting some crazy intensity level occasionally. Even modest increases in activity show benefits.
That's really encouraging. Now, what's the biology behind it? What's the mechanism? How does just moving more offer such profound protection?
It works through several really critical pathways in the body. First, and maybe most importantly for breast cancer, exercise helps reduce circulating levels of estrogen.
Ah, the hormone connection.
Exactly. Physical activity helps lower the amount of free estrogen floating around in the bloodstream, especially after menopause. Second, it's crucial for maintaining a healthy weight and improving insulin sensitivity. Better insulin control means less chronic inflammation and fewer growth factors that can encourage cancer cells to multiply.
Okay, estrogen, insulin, anything else?
Yes. Third, it significantly enhances overall immune function. A healthy immune system is better at patrolling the body, identifying potentially cancerous cells, and destroying them before they can form into aggressive tumors.
Okay, that makes sense. Now, speaking of weight, weight management is another big factor, right? Particularly after menopause.
Yes, critically important. We often see data showing that even what seems like modest adult weight gains, say 20 to 30 pounds gained after the age of 18, measurably increases breast cancer risk later in life, especially postmenopausally.
Why is postmenopause such a key time for weight to impact risk?
It's purely down to hormones again. Before menopause, a woman's ovaries are the main producers of estrogen. But after menopause, when the ovaries shut down, fat tissue actually becomes the primary source of estrogen production in the body.
How does fat tissue make estrogen?
Through an enzyme called aromatase, which is present in fat cells, it converts other hormones into estrogen. So basically, higher levels of body fat after menopause translate directly into higher circulating estrogen levels.
And that fuels many breast cancers.
Exactly. It fuels the majority of hormone receptor-positive breast cancers, which are the most common type. So the focus really needs to be on sustainable, long-term habits that help maintain a healthy body composition over time. Not crash diets, but steady, healthy weight management.
Okay, let's talk about alcohol consumption. This one feels like a particularly tough message for a lot of people because the link with breast cancer risk seems pretty clear and, unfortunately, linear.
It is clear and it is linear. Our sources consistently confirm that there's essentially no safe threshold for alcohol when it comes to minimizing breast cancer risk.
No safe level at all.
That's the hard truth based on the current evidence. It's a difficult conversation, definitely. Every single alcoholic drink consumed per day, and a standard drink is less than many people think is associated with roughly a 7% to 10% increase in breast cancer risk.
Wow. So someone having, say, 2 or 3 drinks most days?
They're facing somewhere around a 20% higher risk compared to someone who doesn't drink alcohol at all. This isn't just about heavy drinking. The risk starts climbing even with low, regular consumption.
So if the relationship is linear like that, does that mean that cutting back offers real benefit? If someone doesn't want to eliminate alcohol completely, does reducing intake still help?
Absolutely. That's the actionable takeaway. Because the risk seems to be cumulative based on total exposure, any reduction provides a measurable risk reduction benefit. Cutting back from 2 drinks a day to 1, or maybe saving alcohol only for specific social occasions rather than nightly, that makes a difference.
Okay, and what's the mechanism here? How does alcohol actually increase risk?
It's thought to work in a few ways. Like excess body fat, alcohol can raise circulating estrogen levels. But it also seems to have a more direct damaging effect. Its main breakdown product in the body, a chemical called acetaldehyde, is a known carcinogen that can directly damage DNA in cells.
Okay, direct DNA damage.
Yes. And furthermore, alcohol can impair the body's ability to absorb and use folate. Folate is a really crucial B vitamin that we need for proper DNA repair and synthesis. So if folate levels are low due to alcohol, cells might be more vulnerable to mutations and carcinogenic changes.
Right, that makes sense. Now, shifting gears to some potentially good news in the prevention landscape. Breastfeeding.
Yes, this is a positive one. There's good evidence that extended breastfeeding, and generally studies define extended as 12 months or longer, cumulatively across all children, measurably reduces a woman's lifetime risk of breast cancer.
How much reduction are we talking about?
The estimates vary slightly, but it's around a 4% to 5% risk reduction for every 12 months of breastfeeding.
Why? What's the protective mechanism thought to be?
There are a couple of theories. One is that breastfeeding helps mature the breast cells fully, making them perhaps less susceptible to malignant changes later on. Another factor is that while breastfeeding, women often have fewer menstrual cycles, which means less lifetime exposure to the cyclical surges of estrogen.
Less estrogen exposure overall. And is there anything particularly interesting about the type of breast cancer breastfeeding might protect against?
Yes, this is fascinating. The protective effect seems to be strongest against some of the most aggressive and difficult to treat subtypes, specifically hormone receptor negative cancers like triple negative breast cancer.
Triple negative, those are often harder to treat, right?
Exactly, they don't respond to hormone therapies. So the fact that breastfeeding seems to offer particular protection against these aggressive tumors, which are also often more common in younger women and certain ethnic groups, suggests a really unique biological benefit.
Okay, one last point in this section. A necessary caution regarding hormone therapy, HRT, sometimes called MHT for menopause hormone therapy, often used for severe menopausal symptoms.
Right, this needs careful handling and discussion with a doctor. The key distinction is usually between estrogen-only therapy, typically for women who've had a hysterectomy, and combined therapy, which includes both estrogen and progestin.
And it's the combined therapy that carries more risk.
Yes, the data is clearest on combined HRT. It definitely increases breast cancer risk, and that risk rises the longer you use it, particularly after about 5 years or more of continuous use.
So what's the consensus guidance for women considering HRT?
The consensus among most oncology and gynecology groups is pretty clear. If HRT is deemed necessary to manage severe menopausal symptoms that are significantly impacting quality of life, the principle should always be to use the lowest effective dose for the shortest necessary duration. The goal is to minimize that cumulative hormonal exposure and the associated risk as much as possible. It requires ongoing conversation with your doctor about risks and benefits.
So our data analysis and really just looking at the world confirms that breast cancer outcomes are intrinsically deeply tied to global equity. We can't talk about progress without talking about fairness.
Absolutely not. The disparities are stark.
And we have to address these disparities even within supposedly wealthy developed nations. We use the U.S. as a really sobering, frankly painful example of how just being a high-income country does not guarantee equal outcomes for everyone.
No, it certainly doesn't. And the statistic regarding Black women in the U.S. is just horrifying, and it hasn't improved enough over the years. They experience a 38% higher breast cancer mortality rate.
30% higher death rate, despite having a slightly lower incidence rate, a lower chance of getting diagnosed in the first place compared to white women. How is that possible?
It's a devastating gap, and it represents a profound, multifaceted failure of the healthcare system.
So why? Why does this deadly gap persist in a country with, arguably the most advanced medical technology in the world? What are the root causes our research points to?
The causes are complex, interlocking, and systemic, but delayed diagnosis is paramount. It's often driven by really significant socioeconomic and access barriers.
Like what specifically?
We're talking about patients struggling with the cost of insurance copayments or deductibles, even small amounts. The lack of reliable transportation to get to appointments, especially multiple diagnostic visits, or the inability to take time off work or find affordable childcare during a lengthy screening and follow-up process. Even seemingly small financial or logistical hurdles can cascade into months-long delays in getting diagnosed.
And by the time they get diagnosed, the cancer may be more advanced.
Exactly. Compounding that, there's the biological reality we touched on. Black women, unfortunately, have a higher prevalence of those aggressive subtypes, like triple-negative breast cancer, which is inherently harder to treat effectively, even when caught relatively early.
And you mentioned geographic variation, too.
Yes, urban versus rural disparities, and even disparities within cities compound the problem. A lack of specialized cancer centers or even basic screening facilities in many rural areas or underserved inner-city neighborhoods means patients often face much longer travel times, fragmented care between different providers. It all further delays timely treatment initiation.
So what are the solutions? What needs to happen to close this gap?
It requires a multi-pronged approach. Things like expanding comprehensive insurance coverage is crucial. Implementing dedicated patient navigation programs, people whose job it is to literally guide patients through the complex system, schedule appointments, arrange transport, has shown real promise. And we need much more culturally tailored outreach and education to build trust and address specific community barriers.
Okay. Now shifting our focus to the Global South, to lower resource settings. There, the crisis seems less about disparities within a system and more about survival itself, a crisis driven by that extremely late-stage diagnosis problem we identified earlier.
That's right. The mortality rates are just disproportionately high because the infrastructure to support early detection and effective treatment often just isn't there. The challenges are structural, and frankly, they can feel overwhelming.
What are the biggest structural challenges?
Well, first, there's often a widespread lack of organized population-level screening programs like routine mammography. That forces cancers to be found mostly through symptoms, meaning, as we said, most diagnoses happen at stage 3 or 4 when cure is much less likely.
And even if it's diagnosed?
Even then, it's compounded by profoundly limited diagnostic infrastructure. Maybe there aren't enough trained pathologists to accurately read biopsies and determine cancer subtypes, which is crucial for treatment decisions. Unreliable electricity is a massive barrier for imaging and radiation therapy. Shortages of specialist oncologists, surgeons, nurses, the list goes on.
And we talked earlier about cultural barriers playing a role too.
Absolutely. Things like cancer fatalism, a deep-seated belief that a cancer diagnosis is an automatic death sentence, so why bother seeking treatment? Or strong preferences for traditional healers over conventional medicine. These can lead to really dangerous delays in seeking care, even when some services might be available.
So given these huge challenges, what are the realistic solutions? We can't just, airlift the U.S.-style cancer center into a rural village.
Exactly. The critical thing here is focusing on resource-appropriate solutions. We have to adapt strategies to the local reality.
What does that look like in practice?
It means focusing first on improving early detection through methods that are feasible, like training local community health workers to perform clinical breast examinations, CBE, effectively. Widespread breast awareness education campaigns that empower women to recognize signs and seek help promptly.
And for treatment?
It means adapting treatment protocols, maximizing the use of cost-effective, off-patent generic medications, streamlining surgical procedures so they can be done safely in less specialized settings. It's about making incremental, sustainable progress with the resources available rather than aiming for an unattainable ideal immediately.
Okay. Now, despite these huge challenges, there's also incredible promise in technology, innovations that might help bridge some of these gaps globally. Let's start with the potential of AI for mammography. You mentioned the NHS is piloting this.
Yes, AI in mammography is a really exciting development with global potential. It can function in a couple of key ways. First, it can potentially improve screening accuracy by acting as a second reader alongside a human radiologist, helping to catch subtle cancers that might otherwise be missed.
Okay, better accuracy. What's the other potential benefit, especially for low-resource settings?
Perhaps more importantly for many parts of the world, AI could significantly reduce the radiologist's workload. In countless countries, the major bottleneck to expanding screening isn't the cost of the machines, it's the severe shortage of trained radiologists to interpret the images. AI could potentially help speed up the interpretation process, freeing up human experts to focus on complex cases, and possibly enabling screening programs to expand.
That sounds incredibly promising. But if we're going to deploy AI systems like this globally, what are the big hurdles, ethical concerns, technical challenges?
The major hurdle we absolutely have to overcome is validation and fairness. AI systems learn from the data they're trained on. If an AI is primarily trained on hundreds of thousands of mammograms from, say, white women in North America or Europe, it might not perform as accurately when analyzing images from Asian, Latin American, or African women. There can be subtle biological differences, differences in breast density patterns, even differences in how the images are acquired.
So the AI could end up being biased.
Exactly. We absolutely need rigorous testing and validation of these AI systems across diverse global populations before widespread deployment. We have to ensure they work fairly and effectively for everyone, otherwise we risk creating a new kind of high-tech health disparity.
That's a critical point. Now, moving beyond imaging, there's the truly game-changing potential of liquid biopsy. What exactly is that?
Yeah. Liquid biopsies are essentially highly sensitive blood tests. They're being developed to detect microscopic traces of cancer that are shed into the bloodstream, things like tiny fragments of circulating tumor DNA, ctDNA, or other molecules released by cancer cells.
So detecting cancer from a blood draw, before it's big enough to see on a scan.
That's the monumental promise, yes. Detecting cancer potentially much earlier than current imaging allows, maybe even at stage 0 or stage 1 routinely. Imagine transforming early diagnosis into something as simple as a routine blood test.
That would be revolutionary. Where are we with this technology now?
It's still largely investigational for screening the general population. There are some tests approved for monitoring treatment response or detecting recurrence. But for initial diagnosis through screening, we're not quite there yet for widespread use. But if the technology can be fully validated for accuracy and reliability, liquid biopsy holds the power to completely transform screening worldwide, making it potentially less invasive, maybe cheaper, and certainly more accessible, especially in rural areas.
Okay, so AI enhancing imaging, liquid biopsies, potentially replacing imaging for screening. This all seems to lead towards the most exciting vision for the future of breast cancer care: risk-based screening, moving beyond just age.
Exactly. We might finally be moving beyond these decades-long, often heated debates about whether screening should start at 40 or 45 or 50 for everyone. The future is about personalized risk assessment.
And what's the technology driving that personalization?
A key part of it is polygenic risk scores, or PRS. This is different from traditional genetic testing, like for BRCA1 and BRCA2.
How so?
BRCA testing looks for rare single-gene mutations that confer a very high risk of cancer. PRS, on the other hand, analyzes hundreds, sometimes even thousands, of common genetic variations across your entire genome. Each variant might only have a tiny effect on risk by itself, but when you add them all up, they can identify women who are at moderately elevated risk, even if they don't have a strong family history or one of those major single-gene mutations.
Okay, so it's looking at lots of small genetic factors combined.
Precisely. It gives a much more nuanced picture of inherited risk for a larger portion of the population. So instead of treating every woman in the 40-50 age bracket exactly the same based just on her age,
A PRS score could tell her doctor, actually, based on her combined genetic profile, this particular 42-year-old has a risk level more similar to an average woman in her late 50s.
Exactly. That's the potential. PRS allows us to define risk with far greater precision. Women identified as having significantly higher polygenic risk could be advised to start screening much earlier, maybe even in their 30s, and perhaps use more sensitive methods like MRI alongside mammograms.
And conversely.
Conversely, women identified as having exceptionally low genetic risk might, in the future, be able to safely start screening later or screen less frequently, reducing their lifetime exposure to radiation and the potential harms of overdiagnosis. It's truly moving breast health towards precision medicine, tailoring the screening plan to your unique individual biological probability of developing the disease.
Wow, this has been an incredibly detailed, really comprehensive look at what it truly means to move from just being aware of breast cancer to actively participating in effective care, both for ourselves and globally.
It covers a lot of ground.
And our synthesis, the main takeaway from the Urban Herald's deep dive here, seems crystal clear. True breast cancer awareness isn't measured by symbols worn for a month. It's measured by consistent, informed action.
Yeah.
It's about the screening appointments we actually schedule and keep, whether it's February or August. It's about the consistent effort towards healthier habits, like physical activity, maybe maintained in July. It's about that ongoing commitment to understanding our own bodies and our own risks.
And we really have to emphasize, alongside that individual responsibility, that sustained progress absolutely requires systemic action globally.
Healing.
It means real investment in building resilient healthcare infrastructure everywhere. It means fully integrating breast health into routine primary care, not just as an afterthought during an annual checkup. And it means challenging organizations that engage in that superficial pinkwashing. Instead, we should actively support groups that are funding tangible care.
Tangible care like
Providing access to screening for underserved women, helping patients afford treatment, funding the critical research that leads to better therapies and prevention strategies, funding care, not just marketing that sometimes profits off the disease itself.
Right. We've covered so much today, from those groundbreaking USPSTF policy changes in the U.S. to the heartbreaking reality of global disparities, and then looking ahead to the coming technological revolution with AI and liquid biopsy. But as we wrap up, what's the final, maybe provocative thought you want to leave with our listeners? Something for them to really mull over.
Okay, I think it comes back to that future of personalized screening. It's undeniably where we're heading. So the question to ponder is this: will the powerful combination of polygenic risk scores, giving us that nuanced genetic insight, coupled with highly accurate AI-enhanced mammography or even validated liquid biopsies, will this convergence finally make that decades-long, often divisive global debate over when to start screening, that simplistic argument of age 40 versus 50, will it finally make it obsolete?
Will technology, essentially end the debate by giving everyone their own answer.
Exactly. Will technology finally empower every single woman with a truly tailored, scientifically validated, effective screening plan based on her unique genetics, her biology, her lifestyle factors,
Yeah.
effectively ending the era of one-size-fits-all age-based guidelines?
That is a powerful question, and one that really defines the next decade of oncology, I think. In the meantime, though, our individual action plan for everyone listening is immediate and achievable.
Yes.
If you are eligible for screening based on current guidelines where you live and you're overdue, make the call. Schedule that appointment this week. Don't put it off.
So important.
Start small, but start today with maybe increasing your physical activity just a little bit or making a conscious effort to reduce alcohol consumption. Small steps add up.
They really do.
And perhaps most importantly, use the knowledge you've gained from this deep dive. Use it to advocate. Talk to your friends, your family members, encourage them to prioritize their breast health, not just in October, but year-round. Every informed action, every conversation moves us collectively beyond simple awareness towards meaningful, life-saving, sustained care.